It's one of the most common immunoassays that we have in the laboratory, only second to thyroid testing really, and vitamin D is a very common concern, but it's one of the main concerns in the immunoassay area of the lab. I mean, that's apart from the fact that it's the most common cancer diagnosed in men, and in the top 3 of cancerous killers of men. Well, it's one of the only blood-based screening tests for cancer that we have, and it started over 20 years ago, and things haven't changed. We haven't found a better way of screening for this common cancer. Imagine you might be able to test urine or semen or imaging, or and people have certainly tried to do that, but nothing's improved on what PSA has done, and PSA itself has improved over the years as well. So it's sort of upped the ante in terms of what capabilities we have. It's true that many men will die with their prostate cancer rather than from their prostate cancer. It's still a concern for men who don't want to die of prostate cancer and don't want to die of some other things but still suffer with their prostate cancer. Something that has changed recently is the imaging of the prostate with MRI. So that in the past, if you had a raised PSA, a warning level of PSA, people, well, frankly, that you just get lots of needles into the prostate and hope that one of them finds the cause of that raised PSA. Whereas now you can image the prostate and target the areas that look like they might have prostate cancer rather than this random sampling, and that's far more effective at picking up those cancers. And not only that, but in the biopsy, in the past it was a transrectal biopsy, which was the most common form, and that had a small risk of infection, but can be quite a serious infection. Whereas now the MRI guided needle biopsies through perineal biopsy have very little risk of infection and are better targeted. So all of that's improved. And then we get into the biopsy level. Once we've got that bit of tissue that's suspect, even that's progressed over the years to a clearer understanding of what type of changes are aggressive and which aren't. And it's a bit unfortunate because we had this scoring system, the Gleason scoring system, which grades things out of 10, and to some men to have a score 5 out of 10 prostate cancer might seem disastrous, like you've got prostate cancer and it's almost a pass mark for what. But a 5 out of 10 Gleason 5 prostate cancer is now considered so benign you don't do anything about it, or even 6. And it's only once you get to 7s or 8s that something needs to be done urgently. So the whole the way of suspecting them, finding them, and diagnosing them is continually changing. Nothing keeps still. It's such an important area that everybody's trying to improve on that system. Because we said, well, people with a family history must have a higher predisposition, and so people with a first-degree relative, a father or a brother that's had, well, they're high risk, and so we should at least start testing them earlier. The aggressive cancers tend to occur earlier. But it's true that probably every week people are finding new genes that contribute to that risk, rather than just the hearsay of family history, looking at DNA to see what elements of that family history are there that are linked to prostate cancer. And so now there are systems where you can search the whole genome to see all the genes that are related to prostate cancer and try to calculate that risk. It hasn't reached quite the strength of the family history. So if, say, a brother with that history means your risk of getting prostate cancer is twice the general population. Whereas the best genome studies we have mean that you're 50% higher, than the general population. But that's still relevant, because a man who knows that they're at higher risk by 50% has the option of testing earlier, and being more rigorous in the way that they do that testing. In the past, we used to say if you've had the prostate gland taken out, which is the definitive treatment for prostate cancer, then if your PSA becomes normal again, as if you've got a prostate, well then the cancer must have come back. Whereas now we're sort of saying that no, if you've had the prostate taken out, your levels of PSA must be virtually zero, and any increase in these ultrasensitive levels means that there may be an early recurrence. The problem is, of the men that have a radical prostatectomy, 1/3 of them have a PSA which is undetectable and nothing happens. 1/3 of them have a PSA which never became undetectable and progresses, which is unfortunate. That's the group we're trying to improve on. And then 1/3 of them have a PSA which is undetectable and becomes detectable. Now, what does that mean? Does it mean that they've got an aggressive cancer back? And usually it doesn't. It means that they've got some less malignant cells that have remained behind and won't cause a problem. Well, the quicker we can get that understanding, the more, the more reassurance that man can have about living a normal life and feeling, a sense that their surgery was all worthwhile. But there's also this other form of treatment which is called active surveillance, which sounds like you do nothing except watch, but it's actually watching very closely. You know that there's something there, and you're wondering what it's going to do, so you watch it very closely, and then as soon as there is some evidence that it needs treatment, then immediately you jump on it. At the moment, we're suggesting you should start at an earlier age, 45 or 50, because many men with a family history have cancer which is too late to treat by the age of 55 or 60. Well, you need to detect it 5 or 10 years beforehand, so you need to start at an earlier age. Once there is a family history, the recommendation is you should think of starting at age 40 or something like 10 years before that relative got theirs.